I'd like to just start off just giving you a few facts and figures, really, and I did this for my benefit more than anybody else's, when I was interested to see, the size and scale of our challenges in the UK against what you're facing over here, and I just wanted to get a bit of a sense of it, but it was quite interesting for me to look at nonetheless. And I suppose the biggest factor for me was the size, the number of people. In the UK population, we've got 55 plus million, and our National Health Service deals with over 1 million patients face-to-face every 36 hours, so that's a lot of face-to-face interactions and a lot of opportunity for things to maybe not quite go to plan. Huge amount of admissions, 16 plus million admissions every day. 18% of the people, those were over 65, and 2.4% of those were over 85. And as you can see from the other blurb at the bottom there, our population ageing demography is on the increase, so it's only set to get much, much worse. So it's a good time to be a passionate person about older persons' care in the UK, as everywhere else, I suspect. In terms of the National Health Service, some people might not be aware of quite how it's set up, so just a sort of a quick overview there. We're split into sort of 209 sort of clinical commissioning groups, which are like little regional areas of how they carve up the funding to secure services in those areas. 135 non-acute specialist trusts, 17 specialist trusts in mental health, community and ambulance trusts. We've got 10 of those alone. Nearly sort of 7,500 GP practices and 850 odd non-profit independent sector organisations, and you can see the breakdown of the staff just on the other side of the screen there as well. So we're talking big, we're talking at scale, which is our biggest problem, I suppose, in terms of the first thing to how do we reach such a huge amount of people in such diverse areas. In terms of falls admissions, every year, well, that year anyway, we saw 421,000 admissions through our acute hospitals that presented with falls, which is an increase of 2.7% from the preceding year, so we know that's on the increase. In that year alone, we saw 12,000 hip fractures, and in our hospitals at any one time we'll have 4,000 hip fracture patients. These are people who've come through the door with them. And they stick around. They're a long length of stay, generally about 19 days, that's the mean time for them. So they are frailer end of the market. They tend to stay in service for a considerable time. And in amongst that data as well, we had 2,500 inpatient acquired hip fractures in that year as well. So we're talking significant numbers. So to say in our terms, falls prevention is a fundamental part of what you do. It's business as usual and shouldn't be seen as something unusual and different. These people are right across our services. What we have done over the last few years is our national audit programs have collaborated together with our hip fracture and our bone health colleagues to look at ortholgeriatric models of care and best practice tariffs. So there is financial incentive for getting things right for patients right first time. So time to table, anaesthetic choices, physicians working with geriatricians to get best outcomes for patients, and it's been highly successful. The data is collected from all of the hospitals across the country. It's transparent, it's published, not in a league table pointy finger sort of a way, but certainly in a look what you can do if you really focus on these particular areas of care, and it's been extremely well received. So a little bit more about all the folks that come into hospital and our older persons population in hospital. In terms of what we see, I don't really like showing these slides anymore. I used to like showing them a lot. I don't now, having been in this job for 3-4 years, because the numbers sort of make my eyes water for a start, but also, so what? So what help does that give me or anybody else looking at those numbers? We know it's a problem. We know there's people falling, and as Francis so eloquently described, just keep measuring things. What does that help us to achieve, really? But that just gives you an idea of sort of the numbers that I have to sort of try and cope with. And the same for mental health hospitals as well, not to forget, they're a very, very frail and increasingly so population. So the numbers are awful. But there are some drivers for improvement at national level. Don't try and read this slide. It's bad enough I have to read all these documents and I know pretty much what most of them say. There is no shortage of bits of paper telling people how and what it is they should be doing. And no wonder then everybody then doesn't know quite where to start with it all. And I'm always minded of the poor, and it's usually a nurse, so somebody often is a physio these days. I'm glad to say that they get handed the fool's card when they join their hospital, and it's yeah, okay then, Julie, you're making you the fool's lead. If you could just crack on and sort all that out. And then they sort of stand there with their eyes rolling, looking at this, and where on earth are we going to start? But in this little test, I'm going to pinch an idea of Francis, which gets you to talk to yourselves. Well, not yourself, you can talk to yourselves, or your neighbour might be more helpful. That this is actually what works. So that is actually me in uniform. There's been far too many pictures of me, I've decided already this morning, but unfortunately here's another one. This is not a mocked up photo shot, okay? This has actually happened on one afternoon. I was just touring the wards with a medical photographer pal and said, come and, because I couldn't think of how to explain to nurses how they could make changes anytime, anywhere, yeah? So if you just turn to your neighbour for the next minute and see if you can spot the hazards, as many as you can spot in that picture. What sort of jumps out to you? Okay. So I got at least 7. Did anybody get anywhere near that or more? Hands up. A few people. So the things that I've spotted, and I swear this is how I found this gentleman. He's sitting, as you can see, in this corner here. There's a window here. And he's sitting in a corner, but I should have said that beforehand. I wasn't trying to trick you, honest. But that was his, I think that was the medical of somebody's leg there anyway, but he's there's a window here. So he's sitting here, locked in, yeah? Helpfully, the person who left him with his frame, which is a start, I suppose, but unfortunately he couldn't do anything with it. And he was more likely to use this as a walking aid, this wheeled trolley. Yeah. As for nutrition and hydration, he had a real choice there, didn't he? A bit concerning. He couldn't reach the call bell, although somebody had left it with him. He couldn't see out because he was a respiratory patient, actually waiting to be repatriated to a high care unit, which was a bit concerning given that his oxygen supplies and everything else was over there. He had 3 pillows and he couldn't see me and neither could I see him, so I couldn't observe him either. So the other thing, of course, even if he'd been in bed and he wanted something, where would he go? Into the void, wouldn't he, and fall over that side. So you can see what happened here, that this person who'd left this professional person who'd left this patient in this, thought they'd done mostly the right things, not necessarily in the right order. So you can see it took me about 2 minutes to sort that situation out, and sometimes it's a fresh pair of eyes sees it. So this is about this sort of complementary, multidisciplinary working, which is so important, I suppose. So yeah, that took no resource whatsoever, and probably improved that situation no end. So what do the guidelines tell us that we should assess then? Well, I was fortunate enough to work on the nice clinical guidelines, which are, I think, well known now right across the globe, but pretty much they sort of work with all the evidence and like figure out what is the most important things that you should be doing. And the big thing was, start ditching those screening tools that sort of maybe they're more likely to fall than others, and just start to think about anybody that's 65 and over in your hospital will more likely fall or be at risk of falling, so start from that premise until it's proven otherwise. And then also think about your younger age groups as well, who could be at high risk of falling because of the long list that you see down there, because it shouldn't be just limited to older people. Of course, if you think about your young Parkinson's patients, your MND patients, for young stroke patients, they are all going to fall into those categories, and therefore they could be at risk. Maybe not be at risk usually, but now they're with you because about something you're about to do to them is going to put them temporarily at risk, because you're going to sedate them, or you're going to chop something off, or put something in them, that they didn't have before. So it's obviously going to change things for them. So that's where your screening tools don't necessarily help you. It's about bringing it right down to individual level. NICE also helps us, I suppose, to try and make the best of the evidence that we've got that's available to us, and they do go to great lengths to try and link up things. So this is guidelines around dementia, delirium and falls, which all interlink. So you can click on, they're all interactive, and you can click on and find out, when you should be doing your dementia assessment, what your delirium assessment, when you should be doing that, and why, and how it links into everything else. So they try not to see things in isolation, certainly in terms of prevention, but also for when harm has come to patients as well. So we've got guidelines around hip fracture, head injury and medicines optimisation as well, in case people are getting stuck about what it is they should be doing and need to make changes and influence at different levels. I mean, you wouldn't necessarily want to show that to your ordinary ward nurse, but maybe your directors of medicine, your directors of nursing and similar, they might be interested in those sorts of levels of work. So it's quite handy for us to help direct people to these. What about investigations? I don't know, did Sherlock make it over here? Yeah. Excellent. Sorry, I've got to get him in there somehow. Investigations, and I've done a few in my time, and I'm sure you have as well. But we do seem to be turning it into somewhat of an industry in England at the moment, and it's almost become, the investigation is the thing itself rather than the learning that comes from it. So I think sometimes you really have to push back and say, why are we doing this if we're not actually going to pull any good learning and new learning out of all of this? That they seem to, in some areas, certainly in England, become the premise of the nurses to do. And I would say that is extremely limiting, because you're missing vital contributions from the team. And we've already seen from the evidence that the interventions have to come from multidisciplinary to be effective. So why exclude them when things go wrong? You should usually include your patients and families as well, certainly in terms of duty of candour and being open and transparent. I don't know if you have it over here, but we have like labels in England about focusing on whether things were avoidable or not. Usually, if anything's going to start make me twitch, it's when they say it's an avoidable or an unavoidable fall. The fact is the fall still happened. You're wasting time and it's distracting, arguing the toss about whether it's avoidable or not. You still have to work out what happened and deal with that outcome. And that all severe injuries like a hip fracture or a head injury don't necessarily need a higher level of investigation for a serious incident, which would be a major big investigation in our world. And I don't know how you do things over here, but they spend 60 days or more on those SI investigations and learn probably not a great deal more than if they would have just done a local investigation. And they may want to think about different models of investigation. Certainly if you've got a big general hospital, so I work for a big 2,000-bed general hospital, we would have had about 46 events a year. So if we did that level of investigation for all of that, I would have done nothing else but. So maybe cluster investigations. There's different models of investigations that you can look at where you can extract the maximum learning. So a bit about the financial cost. I've showed you the slides before where we report about 600 falls a day to our national reporting and learning system. So that's about 5,000 or so moderate injuries, so that would be like your humeral fractures and the smaller wrist fractures or something like that. And then we've got it reports about 1,500 severe harm, so that would be your head injuries and your hip fractures. But we know that there's disparity between reporting. Francis mentioned about reporting and assigning injury severity of harm to that report. We know, because we've triangulated the data, that the National Hip Fracture Database I talked about, that they count very, very well, because they're the patients who actually go to table or actually get an ortholgeriatric or surgical review. So we triangulate that against our own data, and we know that there is a deficit, so that we know there is still underreporting of severe harm. So it's worthwhile maybe digging a little bit deeper. So that's a cultural thing, and you can understand why in some cases if the fall happened here, but you've had to ship the patient off somewhere else to get diagnosed, you're not necessarily going to go back and update your record in this hospital, perhaps, and you can see how it might happen. And the money side of things speaks for itself. They think that falls and fractures in our whole of our social healthcare system cost about £2.3 billion a year. That's certainly an underestimate, and the inpatient aspects of that account for the minority, but still a significant chunk. in the millions of pounds. So there's, you know, I tend to get a bit evangelical myself when, you know, talking about C. difficile, MRSA, and they're talking in binary, you know, they're talking ones and zeros, and I'm talking hundreds and thousands in terms of the impact for older people and the services of which they're in receipt. I talked a little bit before about national audits. So we have we commission an audit for all our acute hospitals and now our community hospitals as well across England and Wales, which extracts the learning from the NICE guidelines and then turns it into audit, and also some other key documents, and turns it into audit tool, which then it's not mandatory, it's voluntary. But that said, we had about 97% take up. This was the last year's. We're just writing up this year's at the moment, but I think there has been some improvement, not a huge great deal if I'm open and candid. But this is a spidergram that sort of shocked me, really, I suppose, that we were woeful at assessing delirium, and yet you talk to staff and if you say go walk onto any ward and ask the staff who are the patients they're worried about falling, it'll be Mrs. Smith with her septic hyperactive delirium, and yet, you know, we don't really know much about it, and we're not doing much about it. And I understand blood pressure, measure checks for orthostatic hypertension. I'll come on to that a little bit in a minute. Medications review was badly done. Assessment of vision, badly done. Mobility aids in reach, not good at all. Continence and toileting plans, better, but not that good. And the call bell in sight actually astonished me because the CQC, you know, we talked about the regulators, they're really hot on where the call bells on patients would be. And you ask nurses where they should be, and they'll all tell you. But actually, when you audit it in cold light of day, that's still, you know, 20% of patients there didn't have the bell near them when they should have done. We excluded patients for whom this wasn't appropriate, so the unconscious and such like. The key recommendation from that year's audit was as follows. It's basically about you need an executive sign-up, which I'm pleased to see, you know, we certainly got in the room here today. You need your multidisciplinary working group. You need to be looking at your bed rail usage, and regularly so. You need to look at your falls risk assessment and make sure it mirrors that's talked about in the NICE guidance, and ditch your risk prediction tool. That particular audit, I think 75% of trusts were still using a risk prediction tool. And I think we could have wept, Francis, when we read that. You know, we thought, oh, goodness me. I have to say, of all the biggest changes this year, we've more than half that as far as I know. So I think that's a huge win in terms of the power of audit and to make change. Out of the programme, we also went on to deliver some resources to help staff, talking to the staff who undertook the audit, you know, what would be helpful. These are the things that came out, really. That line and standing blood pressure, there was no international consensus of what orthostatic hypertension is in acute inpatients. There's plenty written about syncope guidelines, European and international syncope guidelines. These are all for, you know, using beat-to-beat, vena press machines over time, you know, really complex bits of kit. There was no pragmatic guidance of what you're supposed to do on a 42-bedded medical ward, you know, at 3 o'clock on a Friday afternoon. There was none of that happening. So we got together a bunch of the great and the good and surveyed some frontline staff and some falls practitioner staff to say, what do you do? And we come up with some pragmatic guideline, which you can all get. I have got some resources on their way to you. You know, there's lanyard cards that you can put on your, so to remind people how to do it. There's some little crib cards that you can give to undergraduate nurses. I wrote a bit for the Nursing Times. These are all sort of practical things. There's also videos in our e-learning, and I'll mention those later. The biggest thing that we found in the survey was that even falls professionals weren't quite clear what they should be doing, and there was certain variants ranging from somebody who took blood pressure once or twice, maybe 1 minute, maybe at 3 minutes, up to somebody who took 7 consecutive records within 3 minutes. Quite how they did that without the patient's arm falling off is a mystery to me, but they maintained that they did. So what we did was we talked to the experts, we talked to the front line, we looked at what the guidelines said and said, what's the best plan here? And we came up with 1 minute, 3 minutes, and up to 5 minutes of standing up. These are all, you can look at all of these things and click on these links and it'll tell you. And look for symptoms. And a bit about, there was a big nod around the room, and I was really pleased when we looked at the automated sphygmomanometers earlier on in Francis' talk. So do you use them here, or do you use the proper old-fashioned mercury, or not mercury anymore, but manual sphygms, yeah? You don't? Do you use manuals? Yeah. Why do you use manuals? Why do you?
Because they're in the car.
Because they're?
They're in the car.
Oh, because you've got it.
Yeah. They're provided.
They're provided, yeah. So the trouble with a lot of the oscillometric sphygms, so the automatic sphygmomanometers, is that they measure, they take a mean of beat-to-beat measurement across blood pressure. So, you know, if you've got blood pressure going like this, and then all of a sudden it'll take a mean of that. So if you've got somebody who stands up and their heart rate shoots up, that's going to alter the mean. So you're not, we know that there's a 24 thereabouts % discrepancy on most oscillometric meters, and that's written in. We know that. So that's okay if you've got a young, fit 30-year-old and you're just taking a one-off. But if you're talking about diagnostic blood pressure for treatment purposes, that's quite a different story, because it could be, you know, the physician cranking up meds and titrating them quite carefully. So you need to get a really decent reading. So that's why we sort of tend to recommend. And but the reality is, in the way that the wards are so busy, a lot of wards have got the oscillometric electronic sphygmomanometers, and it's the go-to piece of kit. So what we wrote into there, if it says error, and you've just got to keep doing it all the time because it won't work, the chances are your patient's got AF or some other condition that is wrecking the machine and it can't work out for the algorithm. So give it up and just take a manual blood pressure or just a pulse rate and have done with it, basically. So we sort of talked about very pragmatic guidance for staff, which seems to have gone down well. So we've not banned it. I often get accused of Julie Windsor's been banning automatic sphygms. Well, no, she's not, because they're perfectly reasonable for most people. It's just for these people, they're not. There's some of the other resources there. So I work with the Royal College of Nursing to issue these cards to all their undergraduate nursing students, which seem to have gone down quite well. It's just like on a chain that they can pop in their pocket as a reminder. With the Royal College of Physicians, we've done posters, as you can see there. The other piece of work that I really enjoyed doing last year, I must admit, in a perverse sort of way, because I thought at one point it was going to drive me doolally. We got together, when we asked staff about why they were finding it so difficult to do the vision assessment, they were really candid with us and said, basically, we don't know what we're doing. You know, aside from saying, do you wear glasses, that was about the beginning and the end of it. We're going, well, that's not quite what we mean, really. So, and then people got into a panic and thinking they had to start doing some neurological examination or at least get a Snellen's chart out. And we said, no, we don't mean that either, really. And they go, what do you mean? And well, that's a good question. We don't really know. So I got together with all of the main eye colleges, they're all listed down the bottom there, and the Royal Colleges, and said, well, what can we do here? And I painted that picture that I described to you of, you know, it's 3:30 on a Friday afternoon. The nurse has got 3 admissions. She's only been qualified for 2 years. She's got to do 21 assessments on her patient, including a comprehensive falls assessment. And then she's got to check out the vision while she's about it as well. So what is she going to do? So what we did was looked at a really simple test, and it is the grossest of grossest tests, and it just gives you an idea. And I've got some booklets I've had sent over. You can have a look, or you can click on the link there to have a look. But basically, it's like some questions that you can ask patients about whether they can see this, see their paper, or things that you might want to say to patients to try and elicit a response. There's also something you can stand at the end of the bed and say, can you read this, or can you make out what this shape is? So we've measured it for I can never say it right, but it's the font is been measured at distance vision at 2 meters. So the height, so you have to photocopy it as it's in the booklet and then hold it up at the end of the bed. And we've tested it with patients across a range of settings, including patients with dementia, so they could sort of see the little apple and the little cat, and they could understand what that was if they couldn't verbalise what the welcome said. And then there was also a reading version, so you can get a check distance and and reading vision as well. So there's lots of health gains to be had. I mean, things like signing consent. You know, we would say this is how we've sold it to people. If people can't see what they're reading to sign it, how informed is that actual consent? So there's lots of other health gains to be made about making choices for where they sit, what they eat, all manner of things based on vision. We also included the next level, so it breaks down into two sections. The next level is looking at peripheral vision and looking for nystagmus as well. So, but yeah, a lot of the neurological areas will go for that straight off the bat because their staff are used to working in that way. Some of the more general areas like to start off with the very basics and then add on the more complicated stuff. But it is literally wafting pens around, you know, simple as. And it's been very well received. And there's some plans ahead to formally evaluate that in terms of research as well. Because we couldn't find anything available anywhere. So we just had a bit of a punt really, and it seems to have gone down quite well. Patients liked it too. We've got other levers for improvement. So we talked about the CQC, Francis did earlier on, about how you might use their powers, if you like, of inspection to help forward our calls. And before we managed to get this into their standard documentation pack, they just used to ask about falls for 1,000 occupied bed days all the time and get very tied up in knots about whether it was more than the hospital down the road or less than or whatever. And really, that's not the question that we wanted them to ask. We wanted them to ask, what was your numbers compared to your own numbers the year before? Not bother yourself with what's happening to the completely different hospital 100 miles down the road, which is what was happening. So what we've done is tied some of the questions into the national audit in terms of the process measures. So these are very practical things. So we have asked them about the 1,000 occupied bed days, but only in as much as, and how are you doing, and do you look at it yourself to know what your progress of quality improvement is. Then we've also tied it to vision assessment, line standing blood pressure, assessment for delirium, and the proportion of patients with mobility aids in reach. So these are visual, practical things, bedside things that inspectors can look at and talk to staff about. And it ties it all together for organisations, so they're not getting asked the same but slightly different questions all the time. We've actually tried to make it all one thing. The other sort of lever we've got is the GMS contract. Now this is the contract that we ask our general practitioners to sign, and it's basically, you know, their roadmap for the next year, and in amongst that are the financial incentives for checking things, you know, such as, you know, cerebrovascular disease and stroke risk and VT and all the rest of it. They get points mean prizes. We've also, our National Clinical Director for Frailty has managed to get these three questions in about, so every older patient that's seen by a GP will be asked about an annual medication review, whether they fall in the last 12 months, and then it's a bit vague, the last bit, but I think, you know, considering we've got this in there at all is fantastic. So, and we know as well that this is only going to get to the frail end of the spectrum, but that's a starting position in terms of incentivising GPs to investigate. We've also, I think we've been looking very closely to the work that you've done over here, particularly in New Zealand, about engaging your public health strategies, because, you know, that's where the majority of the fallers are, not in a hospital setting. So I've been working with a number of experts across the health and social care spectrum, and we've developed some support for commissioners. You know, I talked about the CCGs, all in the different patches. They commission all their services in their little region. Well, this pack has been developed to help them to commission what looks good for people who are at risk of falling in on a population level. It includes, these are 40-page documents, so I'm not going to go through them all now, but everything from, you know, sort of medication review with the GP, balance and exercise classes, how your local authority can get involved in exercise and mobility, you know, all manner of things in there. And to paint what good looks like and give them examples of where else in the country that they've managed to have success, so they can go to and have a chat with them. So an example of that is, you know, these are the sorts of people that were working on this document, to give a sense of how many different areas we've tried to bring together, and some, as you say, are not-for-profit. situation. So like Age UK is a national charity, a big mover and a shaker in terms of lobbying for improvement. We've got lots of other, the National Osteoporosis Society and the medical colleges and such like. But we've also got some more unusual things like the National Fire Chiefs Council. So there's quite a trend at the minute, I don't know what it's like over here, but using the fire services as a health resource, because they've actually done themselves out of a job. They've been so successful in what they do. They're a highly trained skill force, and they have much more downtime than they do uptime, thankfully. But what can you do to actually to access or use their skills to access older people? So we've got several different projects running across the country, some of them around health and welfare checks. So they can download from their local authority the vulnerable persons in their area, and they might be persons with learning disability, might be older people, might be young at-risk families, drug users. There could be lots of different information on those patients. And they could make fire safety checks, but while they're there, they can also help introduce them to other topics as well. So, did you hear about this? Have you heard about that? Can I leave you a leaflet about that? And they're obviously researching, this is a 3-year project, they're researching it at the moment, but the uptake from people seems to be very positive indeed, because they see it as less intrusive and pointy fingering and telling them that they're a failure. They seem to see it as a positive thing. So I think that's going to work really, really well. They also, the other thing about the fire service, which always makes me giggle when I read about it, one particularly successful exercise program has been extremely successful with older men. So they've taught them to do a Targo program, full exercise training for the full dosed 12 weeks plus, and they do it in the local fire station by the fire officers who have been overseen by a therapist, obviously. And the blokes are beating a trail to go and sit, because they see it as, I don't know, just more acceptable, shall we say, to go with the other 95 ladies to the community hall down the road. They sit, I don't know, what a great idea. There's also our ROSPA, Royal Society of Prevention of Accidents. They're looking at a partnership programme across looking at more voluntary sector providers about how you can utilise some of their skills. Can't tell you too much about the minute. They're literally building that project as we speak, to think who are all these pockets of people that are there providing a service, and how might we draw them together to work for the benefit of older people. Here's some examples of the sorts of things that you get going on. You've got Diane Lloyd and Co up in the north of the country with some steady on. They go out into shopping centres and the like. But I think there's a big push now towards the strength and balance classes and the uptake of those, and commissioning proper services. Julie Bruce and Co are about to publish their trial information for pre-fit. So this was a very large RCT, and we talked about, quality improvement measuring is one thing, but you do need some hard facts back in the background to underpin what you're trying to do. But what they looked at is a 3-arm random cluster controlled trial, where they looked at giving advice with exercise, and then advice and properly programmed exercise across about 9,000 patients. So, and I think, we could probably in the room know what's going to work, and it's, the all bells ringing is going to be the thing that works, and it is. So I think that's going to be quite an important study. Lots of different resources out there for care homes. Some of it are more district level. So the one on the left there, the grey one, that's for what the whole of Scotland does, and they've tied it into their inspection regulators there as well, so that they can properly work together to help assist care homes to do the right things. And we've got sort of local versions going on down in the rest of England as well, which they've sort of locally defined, if you like. Lots of resources out there for patients and carers, some of which are sort of bankrolled by our charitable organisations like Age UK, National Osteoporosis Society. You can go on our online services for NHS Choices. These are all free and open access, and you can follow the links, and it will link you into what you need to know if you're the patient or you're caring for somebody who you're worried about. This one here is quite new, from the audit last year. When we talk to patients and staff about, the information they're given when they're in hospital, some of it varied from extremely good to non-existent. So we worked with a small group of stakeholders, the posh word, people, patients is the real word, and said, what would you like to see? If we told you about this report, what would you like to read about it if you're the patient in the bed? And that's in there. That's what they told us they wanted to hear, and they want it written down. So that's available to you as well. And I think I'd bring some copies over. This is quite an interesting one. This is something we worked with Public Health and the Charter Society of Physiotherapists with last year. And we're trying to target the pre-baby boomer population. We talked about getting in early, and it's very stylistically, and the language and the approach is very much about this early activity and diet and health and well-being and lots of other things. And it's written in a very different way to something like that, which is probably more for the frail end of the spectrum. But even then, we've got people up and doing stuff, not sitting around. We've got other influencing opportunities, and these are, if I'm honest, some of them are a bit more influencing than others, but we've got patient safety collaboratives, which are different to the collaboratives from the IHI that you might have heard about before. But again, these are regionally set up by ourselves and in collaboration with our allied health and science networks, so university base, and they can look at instigating programs to look at how they commission what looks good and good care for patients in community for community prevention examples, but also for there's a couple looking at falls in hospital, but not many, I would say. But there is definite potential, I think, for sharing what looks good in the future. I was advising an NHSI nursing falls collaborative recently, 19 hospitals right across England, and then including mental health and community trusts as well. And we were looking at using the Audit tool as the roadmap, I suppose, to try and help people on their journey to make their improvements, because they knew they wanted to, because they'd done the audit, they knew where they needed to make improvements, so we were just giving them some tools to try and help them on their way. And we were also teaching them about sort of measuring your under-reporting. So Francis's comment about you don't know what you don't know. So we're selling that quite big, and that's been quite a hard sell, if I'm honest. Most people's responses will be report them all. Report them all and go, oh, do you? So you then have to really challenge it. But I think they've made some really good strides forward. I'm sure you've all seen this quote from Francis, and I couldn't put it any better myself, so I won't. I think less focus about one size fits all, and more focusing about the fundamentals of care, which is about independent and individual patient assessment and care planning. That's where it's at, and I think that we should spend more time looking at that rather than trying to get distracted by doing one same thing to all patients as they come through the door, which we know doesn't work. Some emerging evidence that seems to support that theory is about these huddles. I don't know if you've heard of the huddles, safety huddles over here? Yeah. So there's a big project going on up in the north of England called the HUSH project, and this is about patient safety huddles where basically it's after an event, so that's one downside to it, I suppose. The event has already occurred, but it draws together all of your multidisciplinary team to unpick what occurred. And it doesn't have to be big, it doesn't have to be lengthy, it doesn't have to go on for hours. It's literally 5 minutes. Pull all your information around what you know about that person and come up with a change of plan. So this adaptive model. All right, so the thing's already happened, but at least you're responding and not just going to, because what's that old, if you always do what you always did, you'll always get what you always got. So it's trying to challenge that a little bit. We know Cochrane are sitting, I think, right now, working out all the evidence for us. Thank goodness I don't have to do that. So we wait and see what they're about to say, probably going to be the middle of next year, I think. And then after that, NICE will pick up on their work and extend that to our national guidelines as well. That update. I will mention FallSafe, because I was part of it. I was very privileged to be a part of it, and I'm glad that I was. Learnt such a lot. It's a quality improvement project. And we know that things like this do work. And it's probably less about the things that we did, more about the way that we did it. So it's about empowering staff and talking to staff, the frontline people who had the solutions for the problems that just weren't empowered to actually make the changes. So it's about freeing up that energy. And this, thanks to Anna Barker and the team really for this work, because this makes my job so much easier. To be honest, the famous six-pack study that was mentioned earlier. And and what this tells us is if you invest all of your energies into just nursing interventions, you won't get what you're after. You could be chucking the kitchen sink at it all from a nursing perspective, but it won't make a ha'porth of difference. You need to, use all of your pharmacists, you need your occupational therapists, you need your patients, you need your families, and anybody else that can be useful to you to start to think about how you tackle the problems. We're also very grateful to your work here in New Zealand that we know that effectiveness can be achieved at large scale. The work that Sandy and the team have done, 40% reduction in hip fracture, that's a remarkable achievement. And I know you're going to talk about that in some detail, so I'm not going to crash your party there. But, again, this is about this increased multi-professional individualised intervention. The messages couldn't come any clearer. Working in isolation is not going to tackle this problem how we want to. What I will say, I get often questioned about this slide, and I'll be very clear here that I'm not saying these things don't have their place for patient management. They do. But if there's any research, empirical evidence that tells you that these as a single intervention work, there isn't any. But common sense would dictate that for some people, these things are a really good idea. So one of the case studies that Francis talked about, I think was it Mrs. Green or Mrs. Black? I've forgotten her name. But the bed rail dilemma. So should we, shouldn't we? She's the sort of person, other than, you want to find out a bit more about what's going on for her in the first place, like why she needs to get out of the bed and where the bed is and where the loo is and all those sorts of things. But something like a bed alarm might be the solution for her. An early warning alarm. They're not magic. None of these are gravity defying, is what I usually say to staff. The patients will still fall over. But, and one size does not fit all. So giving everybody a falls alarm is not going to be your solution. Do you use those over here, the pressure off alarm? Mm-hmm. Pressure on sometimes. So if you've got somebody with hyperactive delirium, who's like a cat on a hot tin roof, all the thing's going to do is annoy the patient, annoy the staff and everybody else as well. And I've seen them thrown out of windows, I've seen them hidden in cupboards. I think I emailed that Francis once when I was back in full-time clinical work about they'd hidden one in a cupboard, wrapped in a blanket because it wouldn't shut up. So the night nurse had literally wrapped it and put it in the linen cupboard so they couldn't hear it. Which I thought, well, that's, what use was that really? So it's about the individual choice and about what the patient's need is. So similarly for low beds or beds that can go to the height that the patient can make a safe transfer from one place to another or assist them into a safe standing, excellent idea, particularly if you've got bariatric patients perhaps or people with short leg lengths, very, very useful piece of kit for those patients. But just putting all your high-risk falls patients on beds lower to the floor isn't going to solve your problem. Actually, might be causing a few because they're trying to scramble up and get into standing. So not a good idea. A falls aware sign, and that was my own, so I'm quite happy to put that up there. So it's a magnetic sign that used to go above the patient's bed because we thought at the time this would be a really good idea and it would tell everybody, this patient's going to fall over. It tells everybody else as well, so I don't know how you manage with the confidentiality, but there we are. We went with that at the time. But I found over time we were actually asking the wrong question. The question we should have been asking was, why don't the staff know which of the patients that we're worried about with falls? And that the answers were more to do with handover information, opportunity to talk and share information. That was the trouble. And a lot of times they were having these 12-hour shifts, so they were literally having 15 minutes to hand over maybe up to 50 patients. So that level of detailed information was getting way lost. So the question, we were asking the wrong question. So this was never going to be the solution. Similarly to falls armbands. Unless that's going to elicit a particular response for that particular patient, what good's that wristband going to do? Not a great deal. So you get the picture. You get the picture. Hip protectors. There is some evidence that they work for community-based patients, and I know they're very popular. And some people swear by them, and I wouldn't argue with that. So on and so forth. So other things that we've got. You may have seen the later life training. This is your famous Otago training, which I was very privileged to go and visit. I drove through the region. I wouldn't say I went and visited anybody, but I did drive through the Otago region last week. Very beautiful too. But we have later life training that's available, and you can get all manner of staff onto this in England, from your care home staff to your domiciliary staff to your therapy assistants, and they can go on an accredited course. So you can get your activity training, your balance and exercise training into every sort of strata that you can think of. The two e-learning module even, slides that you see there are one that came out of the fall safe, which is preventing falls in hospital, which is we can program it into your we have an electronic record for this. Is a UK-wide training platform in the UK through e-learning for health, so it can be accessed by all hospital staff or any association actually, as long as you register. It's pretty much everything your ward nurse ever needs to know in one place. It takes the nursing one on the left there. If you sat down and did it all in one hit, it would take you 2 hours, and we would never recommend anybody did that, because it's broken up into sections for environment, for cardiovascular risk, for vision, delirium, lots of case studies. There's an exam in it. There's all manner of videos in there. There's patient videos in there, but you can carve it up and do it in little chunks. And therefore, the benefit of that is if you have that as a standard training program in your organisation, you can then free up your falls experts to maybe do bespoke training off the back of investigations, particular things that need to be attended to, rather than just the churn of doing training the whole time. You can get the basics under the belt and then leave your experienced staff to train more specifically. They've got the other one here on the right hand side is we developed as the result of the audit 2 years ago, the National Falls Audit, and that's particularly for junior doctors. So these are FY1 or FY2 levels of people that are sort of fairly junior, and generally the people that would be called to a fall in a hospital, in the middle of the night, and they have not any idea what it is they're supposed to be doing for the patient, let alone how to get them up off the floor safely or examine them, or what the rules and regs around head injury guidelines are and scanning and all the rest of it. So that e-learning module there is accompanied by a workbook we developed with the Royal College of Physicians, and it's all freely downloadable, and I've got some little memory sticks as well. Hopefully you'll be able to get those out to you after today, so you can have a look for yourself and see what it offers. There's videos in here, so there's a video of a patient with a fractured hip, patient with a head injury, and it talks through the doctor's decision making about how they do this. The videos are very realistic. We filmed it up in a community hospital with real patients, and in fact the patient who's on the floor was the tea lady in the League of Friends shop, who I think should have had an Oscar. It was an absolute winning performance. And there's one particular scene in it, we didn't tell the staff what was going to happen, so the patients are behind a double door like that. And they were real patients. They all put their hand up, they wanted to be in this. And somebody stood behind the door and threw something, I don't know what it was actually, they threw on the floor, made this almighty crash. Outside the door you had the nurse and the doctor talking about a discharge prescription and about TTOs and getting this all sort of very intensive discussion. And all of a sudden this almighty crash to the floor, and you actually see the two staff, luckily they managed to not say anything too rude on camera, but it was a real moment where they then leapt into the room. So it is very well done, I think. There's also some environmental, like Where's Wally? So you've got a 360 camera in the wall, and it's go around, hover the mouse and see where all the trailing wires and things are. And it's deliberate that we put the environmental module in the nursing and the doctor's one to give a very clear message. It's everybody's business. Oh yes, that's some of the sort of images from the e-learning. So sorry, me again, but one of France's too. So John, I wish I'd shown you John, but I think many of you have seen John before, because he was an absolute find of a patient by Francis, who tells a very real, moving story about his recovery after stroke and how he fell in hospital and how he felt and how cold he was and how, you know, it worried him and frightened him, and it took him a long time to get his confidence back. Very moving. There's videos on how to do line of standing blood pressure, how to do mental test scoring, how to assess patient for walking aids, neuro-obs. Oh yeah, where's Wally? Spot the hazard picture there as well. And the doctor's one, aside from, oh yeah, there she is on the floor for the head injury. That isn't real blood, I can say. I probably was ketchup. But we've also got case studies in there as well so they're looking about taking histories for syncope and just case studies for the doctors to work through. It takes about an hour, I would say, the doctor's e-learning module end to end. So the workbook they can work through with their supervisor and share that as part of their CPD learning programme. And that's about all I had to say. So thank you very much indeed for your time.